This is a chest radiograph of a young woman with asthma who presented with worsening shortness of breath. The frontal radiograph shows a vague, triangular opacity projected over the right midzone that effaces the right heart border, representing the silhouette sign. There is associated volume loss, most evident by mild elevation of the right hemidiaphragm. On the lateral radiograph, there is a triangular opacity with its apex directed towards the hilum and its base abutting the anterior chest wall, characteristic of right middle lobe collapse. The upper border of the opacity corresponds to the minor, horizontal fissure, and the lower border to the major fissure, which explains why the minor fissure is no longer clearly seen on the frontal view due to its inferior displacement. The key finding here is the triangular retrosternal opacity on the lateral film, confirming lobar collapse. The frontal film alone can sometimes be subtle and easily mistaken for pneumonia or poor inspiration. The presence of volume loss, however, strongly supports collapse rather than consolidation. Right middle lobe collapse is the lobar collapse least associated with overall volume loss because it is the smallest lobe in the right lung. Early collapse typically presents with loss of the right heart border, the silhouette sign. As the collapse progresses, the minor fissure is pulled inferiorly out of its usual horizontal position, leading to the triangular opacity on the lateral view where the major and minor fissures approximate each other. The most common cause of right middle lobe collapse is mucus plugging, particularly in patients with asthma or other obstructive airway diseases. Other causes include inflammatory strictures, bronchiectasis, or external compression from lymphadenopathy or tumor. When chronic, the condition may be referred to as right middle lobe syndrome, which represents recurrent or persistent non-obstructive collapse due to inflammation and poor bronchial clearance. The main differential diagnosis on the chest radiograph is right middle lobe consolidation due to pneumonia, but in this case, the clear evidence of volume loss, demonstrated by hemidiaphragm elevation and fissural displacement, supports collapse rather than infection. In terms of management, for simple collapse due to mucus plugging, the treatment focuses on pulmonary toilet, including physiotherapy, hydration, and if needed, bronchoscopy to remove the mucus plug. If a central obstructing lesion is suspected, bronchoscopy should be performed both diagnostically and therapeutically to exclude a mass. In summary, this case demonstrates a right middle lobe collapse secondary to mucus plugging in a patient with asthma, with classic findings of a triangular opacity effacing the right heart border on the frontal view and a dense triangular retrosternal opacity on the lateral view, a highly characteristic and important pattern to recognize in the exam.